Thank you, Madam Chair. Much like other industries, the growth rate that we're seeing in AI within healthcare over the last few years has dramatically expanded, offering the potential to fundamentally alter how care is developed and delivered. A key area of this growth is in the FDA-approved AI-enabled medical devices. Just over a decade ago, there were just 6 approvals by the FDA for AI-enabled medical devices. Today, that number exceeds 600. CMS has begun to offer some level of coverage for software-based technologies to support clinicians and is currently seeking input as part of the proposed CY26 physician fee schedule and outpatient payment rules. However, I believe that more can be done here to provide a sustainable and consistent pathway for these devices under Medicare. This is why I've been working with Senators Round and Heinrich on introducing a House version of the Health Tech Investment Act, which would do just that. Dr. Mello and then Dr. Abraham, do you feel that the lack of a stable environment for a reimbursement for these new devices makes it much more challenging for rural and small hospitals, like those that I represent in Pennsylvania's 13th Congressional District, to invest and ensure that rural patients and communities have access to the latest innovation? First, Dr. Mello.
I do. There's no question that when you're trying to just get through the day, thinking about innovation and staying on the cutting edge of future care is not possible in the thought space and resources that you have. So there are many things we can do to provide direct assistance to rural hospitals, both in the academic sector, but also in the policy sector. And the reimbursement piece, as you said, is critical. I think the the FDA example that you began with is really illustrative because that is an area where, despite regulation, despite clearance processes, we've gotten a lot of those innovations out broadly to hospitals. These are overwhelmingly radiological tools. Of the nearly 1,000 applications approved by the FDA, overwhelmingly, these are radiology tools, and we've done a good job getting them out into practice.
And do you see that mostly those are in major metropolitan areas and not in rural areas?
You know, again, it depends on whether there's a mechanism for billing for that extra. And it's really critical to remember the extra is not just the cost of buying the thing. The extra is the cost of training radiologists on how to use it and making sure that it's working well for everybody. And that's where a rural hospital might be willing to adopt, but not do the work of keeping people as safe as they could be.
Dr. Abraham, could you please comment?
Thank you so much for the thoughtful question, Doctor, and I appreciate you bringing up rural health. Some of the most impressive improvements we've seen in stroke care from our technology have been in rural work. That one of the references in interventional neuroradiology in my testimony was from Texas, sharing that in deep rural Texas, we were able to improve some of the time to treatment by 80 minutes in stroke patients. You are correct to identify the tension there, that when hospitals make a decision about whether or not to adopt the technology, the ability to get reimbursed for it is front of mind. If we are able to identify ways to reassure hospitals that there will not only be temporary payment, but sustained payment for technologies that have already gone through the rigor of the FDA and gotten approved as safe and effective, that would do a lot to help improve the adoption of these technologies.
Thank you. In my remaining time, I want to pivot to Dr. Toy. We recognize the opportunities that AI has provided. It is loosely regulated usage and prior authorization that is my concern. In fact, in March of 2025, the AMA uncovered that over 60% of physicians are concerned that the expanded use of AI in prior auth is exacerbating the rate of incorrect care denials, over 60% of doctors. Given this concern from physicians, do you feel that AI should be leveraged in the AI prior authorization decision-making process? And if that answer is yes, what guardrails should be put up?
Thank you for the question there. So definitely in the case of prior auth, I think that right now at Clover ourselves, we do not use AI in any form within the prior authorization process.
But are you aware that many Medicare Advantage plans utilize and Medicaid managed care plans do as well?
Absolutely. And I think that from our position, they should not be used in any kind. AI should not be used to review, to deny in any case. Like, that is not a good use of AI. I do not think AI is ready to do that right now, which is, I think is the problem you're addressing. There are use cases where it can reduce burden, accelerate getting to yes faster. Those are good places you can use AI, but not to deny care. That should
Do you
not be.
feel that if AI does cause a denial or refusal of care, that there should be a person-to-person, a physician-to-physician evaluation?
Absolutely. A peer-to-peer is always appropriate, and that should be in all cases, maybe not even a denial if requested or if appropriate. A human clinician should always be the one making those decisions.
Thank you for your comments. Madam Chair, my time has expired, and I yield back.